Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Our topic today about adenomyosis and infertility. So, what are the objectives of this lecture? The definition of adenomyosis, epidemiology, etiology, histological classification, diagnosis, effect of adenomyosis on infertility, and of course, the pregnancy outcome. And lastly, the treatment. So, what is the definition of adenomyosis? Adenomyosis is a benign condition of the uterus characterized by the foci of endometrial tissue invading the myometrium at a depth of at least 2.5 millimeter below the basal layer of the endometrium. Please look to this picture. This is brownish in color is the endometrium which invade the myometrium. Endometriotic foci dispersed through the myometrium here. This is diffuse adenomyosis. Okay, this is the site of the endometrium. The normal site is in the uterine cavity here. But in case of adenomyosis, this endometrial gland and the stroma invade the myometrium, as you see here, causing diffuse adenomyosis or cause adenomyoma or cause focal adenomyosis. Okay, so this is the definition of adenomyosis. Presence of this endometrial gland and stroma beyond the depth of at least 2.5 millimeter below the basal layer of endometrium is considered adenomyosis. Okay, what about epidemiology? The prevalence of adenomyosis varies from 5 to 70%. Imagine how big is the range of this prevalence from 5% to 70%. Why this? Because there are different studies and different types of population and different types of classification according to histopathology and according to imaging modalities. That's why ranging between 5 to 70%. And the diagnosis is confirmed with histopathology after hysterectomy. This is a definite diagnosis. Okay? Okay. However, I can suspect adenomyosis using imaging modalities like transvaginal ultrasound, 2D or 3D ultrasound, or by using MRI, magnetic resonance imaging, and so on. Okay, the diagnosis of adenomyosis is more common in women between 40 and 50 years old. This constitutes 70 to 80% of cases. Those below the age of 39, women below 39 years old, constitute 5 to 25%. Okay, diffuse type of adenomyosis is more common than focal type. Remember the picture, the first slide? Yeah, diffuse type is more common than focal type. And the disease also develops more often in the posterior wall of the uterus than in the anterior wall of the uterus. And rarely seen at the cornea and at the isthmic region. Okay, so The commonest site is the posterior wall, and the posterior wall is commoner than the anterior wall. And the rarest site at the cornea and at the internal os or isthmic region. The most common risk factors for adenomyosis are multiparity, age more than 40 years, previous cesarean section, or uterine surgery, like myomectomy, like dilatation and decurettage, okay? Any uterine surgery or previous cesarean section or age above 40 or multiparity, all of these considered risk factors. What about the etiology? The etiology of adenomyosis is still not clear, as the exact underlying pathogenetic mechanisms are not completely known. However, we have four theories trying to explain why adenomyosis happens. The first theory, which is the most popular one, is based on invagination of the endometrial basalis into the myometrium due to defect or weakness at this junction. Weakness may be due to trauma from childbirth or D&C or whatever, or inflammatory reaction. So this is the first theory, invagination of endometrial basalis into the myometrium due to defect or trauma at the junction between endometrium and the myometrium. The second theory describes a de novo origin of adenomyosis from misplaced pluripotent Mullerian remnants. So we are suspecting that there is Mullerian remnants in the muscle wall of the uterus, and this pluripotent Mullerian remnants will cause adenomyosis. The third theory suggests that invagination of endometrial basalis proceeds along the myometrial lymphatic system. So through lymphatics, vascular lymphatics, the endometrium goes through the myometrium, causing adenomyosis. The fourth theory proposed that adenomyosis originates from bone marrow stem cells. So this is the four theories trying to explain what the adenomyosis, but up till now, the etiology is not definitely known. What about histological classification of adenomyosis based on depth of invasion? As you see here, there are many studies explaining the classification of adenomyosis based on depth of invasion. Of course, this is histological classification. For example, in 2006, there are four grades. First one, invasion more than 2.5 millimeter from endometrial junction. Grade 2, mild cases, 1/3 of the uterine wall is affected. While the moderate cases, 2/3 of the uterine wall is affected. While the severe form or severe cases, more than 2/3 of the uterine wall affected. Okay, more than 2/3. Okay, according to some more Etal 2002, He said we have four groups, group A, B, C, D, according to the depths of invasion also. A up to 25% of the wall, group B between 26 up to 50% of the wall affected, group C between 51 up to 75% of the wall, group D more than 75% of myometrial thickness affected. And you can read the other types of histological classification as you see here in this slide. But no universal histological classification of adenomyosis up till now. All these are suggested histological classification according to the depth of invasion. What about the diagnosis of adenomyosis? Symptoms of adenomyosis include chronic pelvic pain, dysmenorrhea, heavy menstrual period, and infertility, and maybe miscarriage. Additionally, adenomyosis is associated with greater incidence of anxiety, depression, and psychological stress. However, you should know that approximately 1/3 of women with adenomyosis are asymptomatic. 1/3 of women with adenomyosis are asymptomatic. During examination, the uterus is enlarged symmetrically in case of diffuse adenomyosis or asymmetrically in case of focal adenomyosis, and tenderness can be positive. Okay, so enlarged tender uterus may be symmetric or asymmetric. What about imaging? Let us start with the ultrasound, with the two-dimensional transvaginal ultrasound, which had a sensitivity and specificity of 83.8 and 63.9% respectively. So as you see, transvaginal ultrasound, the two-dimensional one, has high sensitivity as you see, and moderate specificity. Okay? What are the features as in this picture of adenomyosis by 2D transvaginal ultrasound? Can you see the blue line here? Extending from endometrial line, which is S-shaped in case of adenomyosis. This is the posterior wall thickness, and this is the anterior wall thickness. You can find asymmetry in thickness between posterior wall and anterior wall. Of course, the thickness of posterior wall is longer than the thickness of anterior wall. Okay? What else as a sign by ultrasound? Presence of intramural cyst. Intramural cyst. Like this one, like this one, like this one. Hyperechogenic islands, like this one, the yellow plus here, hyperechogenic islands here, and here. This is another sign. Subendometrial linear striations, as in this area, the blue plus. Okay. S-shaped endometrium, as you see here. Distorted junctional zone. Distorted junctional zone, also another sign. So, what else as a signs of ultrasound, symmetrically enlarged uterus without definite leiomyoma. In absence of leiomyoma, but, but symmetrically enlarged uterus. So all these are signs of adenomyosis. Again, asymmetric thickness between the posterior wall and the anterior wall, myometrial cysts, hyperechogenic islands, subendometrial linear striations, okay, distorted junctional zone, S-shaped endometrium. This is the feature I said. What about three-dimensional transvaginal ultrasound? Three-dimensional transvaginal ultrasound can be used for better visualization of junctional zone with a sensitivity of 85% and the specificity of 81%. Okay, this is good sensitivity and the good specificity for evaluation of the junctional zone. But three-dimensional transvaginal ultrasound has a pooled sensitivity and specificity for all combined imaging characteristics of 88.9% and 56% respectively. So sensitivity is high here, as you see, constitutes 88.9% specificity, while the specificity is average 56%. Okay, so three-dimension transvaginal ultrasound have high sensitivity in diagnosing adenomyosis. What is the feature of adenomyosis on 3D transvaginal ultrasound? Irregular or interrupted junctional zone, or junctional zone more than 8 millimeters, and a significant difference between maximum and the minimum thickness measurement of junctional zone more than 4 millimeters. So the difference between the maximum junctional zone in certain area and the minimum thickness measurement of junctional zone more than 4 millimeters. Okay, let us look to this picture of three-dimensional transvaginal ultrasound. The yellow line here measuring the junctional zone between the endometrium and the myometrium. And this is the maximum one, of course, more than 8 millimeters, denoting adenomyosis. And this is the minimum distance of junctional zone. As you see, the difference between the maximum and the minimum is more than 4 millimeters. This is a sign of adenomyosis. Infiltration of lateral wall, this is coronal view. Infiltration of the lateral wall, also a sign of adenomyosis, endometrial glands. Okay. So the advantage for transvaginal ultrasound, three-dimension, is to evaluate the junctional zone, as I said before. Okay. What is imaging, other imaging technique or modalities? Magnetic resonance imaging, or what's called MRI. MRI has also been proven to be a very accurate in diagnosing adenomyosis, although it is more expensive method compared to transvaginal ultrasound, and of course need an experienced physician. Recent post-operative prospective studies have shown a sensitivity of 77% and the specificity of 89% for MRI. So it has a higher specificity, as you see, 89%, more than 2D or 3D transvaginal ultrasound. The specificity of MRI is high. So, what about MRI finding in adenomyosis? MRI finding considered diagnostic for adenomyosis include a large asymmetric uterus, an abnormal junctional zone to myometrial thickness ratio of more than 40%, and the junctional zone thickening of 8 to 12 millimeter. Look to this picture, please. This is a picture of MRI for case with adenomyosis. The yellow line here measuring the junctional zone. This is for the anterior wall, and this is for the posterior. As you see, of course, you can find the difference. The junctional zone here is above 8 millimeter. Also, the abnormal junctional zone to myometrial thickness ratio more than 40%. This thickness more than 40% to the ratio of myometrial thickness. Okay, in relation to ratio of the abnormal junctional zone to myometrial thickness ratio of more than 40%. Okay, and at the same moment you can find junctional zone thickness more than 8 millimeter. You can find it 8, 9, 10, 12 millimeter and so on. Okay, so MRI definitely can evaluate the junctional zone with high accuracy. It is an accurate method for diagnosing adenomyosis. But of course, it is expensive. Okay, look to this classification of adenomyosis based on imaging technology. Either MRI, as you see, or transvaginal ultrasound. Let us see the most recent classification according to transvaginal ultrasound published in 2020, 2019. They divide it into 5 categories or 5 types. The first, diffuse of outer myometria. Diffuse adenomyosis of outer myometria. The second is diffuse adenomyosis of the inner myometria or junctional zone. The third, focal of the outer myometria. The fourth one, focal of the inner myometria. The fifth type is adenomyome. Okay, so this is according to recent classification of adenomyosis based on imaging technology. Let us see another study using MRI published in 2014. In their classification, they have 1, 2, 3, 4 types. The first is diffuse adenomyosis, the second is focal adenomyosis, the third is polypoid adenomyosis, and the fourth is other varieties. Okay? This is a problem of adenomyosis. We have no one definite classification according to imaging technology, and we have no single classification accepted all over the world at histological classification according to the depth of invasion. That's why the prevalence of adenomyosis is different and ranging between 5 to 70%. We have no worldwide accepted one classification, one histological classification for according to depth of invasion, and we have no one accepted worldwide imaging classification for adenomyosis. Okay, a definite diagnosis of adenomyosis is made for histological examination, is made from histological examination after hysterectomy. Histological examination of endometrial invasion of the underlying myometrium. So when we do histopathological examination, we will find endometrial glands and the stroma invading the myometrium. This is the definite diagnosis of adenomyosis. Okay, based on histopathological examination, adenomyosis is classified into 3 categories: focal adenomyosis, diffuse adenomyosis, and adenomyoma. Focal adenomyosis if circumscribed nodule of endometrial glands and stroma surrounded by normal myometrium. Okay, this is the focal adenomyosis. There is endometrial gland and the stroma surrounded by normal myometrium. While in diffuse adenomyosis, endometrial glands and the stroma distributed throughout the myometrium, affecting the whole anterior wall or whole posterior wall. And we said before, posterior wall adenomyosis is the commonest or commoner than anterior wall adenomyosis. Okay? So, endometrial glands here in diffuse type, endometrial gland and stroma distributed throughout the myometrium. While in focal adenomyosis, there is circumscribed nodule of endometrial glands and the stroma surrounded by normal myometrium. Okay? What about the third category in histopathological examination classification? Adenomyomas. Adenomyomas are considered a subgroup of focal adenomyosis. So how can I differentiate between focal adenomyosis and the adenomyoma? In adenomyoma, the endometrial gland and the stroma is surrounded by hypertrophic myometrium. This is the difference. Endometrial gland and stroma is surrounded by hypertrophic myometrium. while in focal adenomyosis we said it is surrounded by normal myometrium. So if it is endometrial glands and stroma surrounded by hypertrophic myometrium, we call it adenomyosis. Okay? If it is endometrial glands and stroma constitutes circumscribed nodule and surrounded by normal myometrium, this is called the focal adenomyosis. If endometrial glands and stroma distributed throughout the myometrium, affecting large part of the uterine wall, this is called diffuse adenomyosis. Okay? So, let us see the effect of adenomyosis on infertility, how it happens. The suggested mechanism of how adenomyosis causing infertility or miscarriage can be explained by the following. Destruction of normal myometrial architecture and function. Disturbed uterine peristalsis and the sperm transport. I need the uterine peristalsis for sperm transport and for the fertilized ovum to be implanted in the endometrium. So, disturbed uterine peristalsis can cause infertility. Reduced expression of implantation markers. Increased intrauterine pressure. Local hyperestrogenism. An abnormal inflammatory response. The increased presence of free radicals and hypervascularization and defect in adhesion molecule. But you should notice that the effect of adenomyosis on fertility may happen because infertility may happen because the presence of concomitant pathology. What is the concomitant pathology commonly associated with adenomyosis? Two pathologies very common with adenomyosis: endometriosis and leiomyoma. And both of them can affect the fertility, can cause infertility or miscarriage. So maybe the cause is due to these associated pathologies like endometriosis or leiomyoma. Okay? Okay. Please remember this association because it is common. And both of them, endometriosis and leiomyoma, are hyperestrogenic disease like adenomyosis also. So there are common associations between adenomyosis, endometriosis, and leiomyoma. Let us go to treatment. Treatment options are highly dependent upon a woman's age, other fertility factor, and symptomatology. Is the woman symptomatic or not? She has a chronic pelvic pain, dysmenorrhea, heavy menstrual bleeding, infertility, miscarriage. So, symptomatic or not? She is young or she is older than 50 or 50 years old and so on, or she is young, childbearing age. So the age is important, and symptoms, of course, important. The primary indication for the treatment of adenomyosis is the presence of symptoms negatively affecting patient daily life. Although the standard method of treatment for adenomyosis is hysterectomy, the use of conservative medical or surgical options offer relief of symptoms and maintenance of fertility of patients. So, if I am searching for fertility for the lady, so I'm going to use conservative medical or conservative surgical treatment, not hysterectomy, of course. I can control the pain, I can improve the fertility. Let us see the details of these big categories: medical management and conservative surgical management. First lines of conservative medical management include non-steroidal anti-inflammatory drugs and the hormonal control of excessive cyclic bleeding. Unfortunately, none of the available medical therapies can treat symptoms of adenomyosis while still allowing the patient to conceive. So, you may give medical treatment controlling pain, but can't improve the infertility or manage the infertility. Okay? Okay, supportive hormonal treatment such as continuous use of oral contraceptive pills, high dose progestins, levonorgestrel releasing intrauterine device, danazole, aromatase inhibitors, and selective progesterone receptor modulators can temporarily improve symptoms and induce the regression of adenomyosis. What about GnRH agonist treatment? Gonadotrophic releasing hormone agonist treatment with add-back estrogen therapy. So you give GnRH agonist with add-back estrogen therapy like Primarine and so on. Can be beneficial for infertile women with adenomyosis because of its positive effect on endometrial implantation markers, leading to improved implantation rates. What else? Positive effect? A reduction of lesion size and improving patient quality of life. All of these improve chances of conception. So please remember that using GnRH, gonadotrophic releasing hormone agonist, with add-back estrogen therapy can be beneficial for infertile women with adenomyosis because of its positive effect on endometrial implantation marker, leads to improved implantation rate, a reduction of lesion size, and patient quality of life is better. This improves the chances of conception. Okay? Please remember this because it is important. Okay, what else? The long-term preparation of endometrium with GnRH therapy for 2 to 4 months before frozen embryo transfer in women with adenomyosis undergoing IVF is associated with significantly higher clinical pregnancy, implantation, and ongoing pregnancy rates. So, in some studies, they found that if you give the patient GnRH agonist therapy for 2 to 4 months before frozen embryo transfer in women with adenomyosis undergoing IVF is associated with significantly higher clinical pregnancy and higher implantation rate and higher ongoing pregnancy rate. Okay, what about levonorgestrel IUD? Pre-treatment with levonorgestrel IUD for 3 months before embryo transfer has been proposed to improve the reproductive outcomes of patients undergoing in vitro fertilization with a significantly increased ongoing pregnancy rate. And this is proved in some studies. Okay? Let us go to the conservative surgical treatment. The surgical treatment of adenomyosis-related infertility remains a highly controversial issue regarding the impact of surgery on reproductive outcome. Many methods and techniques, such as electrocoagulation and the adenomyomectomy, with or without myomectomy, have been described, either by laparoscopy or hysteroscopy or laparotomy. Each method has its own advantages and risks. Proper conservative surgery could be an alternative treatment for infertile women with adenomyosis, as successful pregnancies have been reported in many cases. So, in some studies, they found that using this conservative surgery resulted in good pregnancy outcome or successful pregnancy outcome. Conservative surgical treatment aims to balance the advantage of removing the affected area against the disadvantage of leaving a possibly defective uterine wall. So you should search for this. Please notice this point. Conservative surgical treatment aims to balance the advantage of removing the affected area against the disadvantage of leaving a possibly defective uterine wall. Factors like the extent of excision of the myometrial defect, the reconstruction technique, post-operative infection, and surgeon experience are quite important. All of these are quite important when you decide to do conservative surgical treatment. What is the extent of excision of the myometrial defect? What is the reconstruction technique you are using? You took all measures to prevent post-operative infection. Is the surgeon experienced very well to do this surgery? This is all these factors are important. Even the use of electrodiscermy instead of cold knife during the operation might affect the wound healing and the integrity of the myometry. Some expected complication of conservative surgery may include some suspected complication of conservative surgery include the development of abdominal and intrauterine adhesions, either abdominal adhesions, intraperitoneal adhesions, or intrauterine adhesions. What else? If pregnancy happen, there is possibility of placenta accreta, spectrum, and uterine rupture in the future pregnancy, especially during the second and third trimester of pregnancy. So, conservative surgery for adenomyosis may be complicated by placenta accreta and uterine rupture in future pregnancy, especially during second and third trimester of pregnancy. What about hysteroscopy? Hysteroscopy could be an alternative for cases with cavity alteration induced by adenomyosis, and metroplasty for T-shaped uterus could lead to higher live birth rates and reduced miscarriage. Okay, so hysteroscopy again could be an alternative for cases with cavity alteration induced by adenomyosis. In case of adenomyosis, with alteration of the uterine cavity, affecting uterine cavity, and the metroplasty for T-shaped uterus could lead to higher live birth rate and reduced miscarriage. This is the end of my lecture, and this is some references. You can read more in these published articles. I hope this lecture was clear enough. Please remember my scientific site on Amazon, where you can find my published books. You can find Kindle edition and hard one on Amazon site, textbook of obstetrics, textbook of gynecology, contraception handbook, multiple choice question book, medical disorder in pregnancy, and gynecologic oncology. This is my box published on Amazon, and this is the link in red. I'll put it in a comment. Another scientific site is my YouTube channel, where you can find other lectures like this one in obstetrics and gynecology, case scenario discussion, multiple choice question, ask stations, guidelines, descriptions, and many other lectures related to obstetrics and gynecology. And I'll write the link of my YouTube channel on a comment. The third scientific site is my site on Blogspot, where you can find some picture of my operations and some articles. Thank you, everybody. My best wishes for all of you.